Dr. Karen Florio um, um, is an associate professor of obstetrics and gynecology at the University of Missouri School of Medicine, where she serves as the vice chair for patient safety and quality, director of the cardio obstetrics program, director of labor and delivery, and director of the maternal fetal medicine fellowship. A nationally recognized leader in maternal cardiovascular health, Dr. Florio has dedicated her career to improving outcomes for pregnant and postpartum individuals through multidisciplinary modules of care, quality improvement, and clinical research. Dr. Florio is the co-principal investigator of the NIH-funded HOPE study, that's Heart Outcomes and Pregnancy Expectations, which is the largest prospective U.S. study evaluating maternal and cardiovascular outcomes among pregnant individuals with heart disease. She is also the chair of the Missouri Pregnancy-Associated Maternal Mortality Review Committee and serves in leadership roles with the Missouri Perinatal Quality Collaborative, ACOG District 7, and the Society for Maternal Fetal Medicine. Drawing from both her personal and professional experience as a preeclampsia survivor, Dr. Florio is passionate about transforming the maternal health system, advancing equity in healthcare, and building the next generation of cardio obstetrics programs nationwide. And I will say that one of the things I told my niece when she was in high school and she was having trouble fitting in, that you will find your people. And Karen Florio is my people. So I'm really happy to have her here to work with, to talk to us today on and about the HOPE study and the work that is being done. So welcome, Dr. Florio.
Thanks, Connie. Now, let me tell you a little bit about Dr. Graves too. So when I was looking for a new job, when I left my old job, I just picked up the phone and called Dr. Graves. I didn't even know who she was. And she was so kind. And that's how we became friends because I was looking for advice. So I'm going to go ahead and share my screen. So the love is mutual, Dr. Graves. Okay. Really excited to come talk to you guys today about kind of my journey through this space. I am a normal small town Midwest girl who just happened to have something really unfortunate happen to her, which really drives what I do every day. And that's kind of what I want to talk to you guys about today. So I have no conflicts of interest. I should say that out loud. But if you know me, you know that I love coffee, chocolate, and grant funding. So there's my Venmo in case you want to send me anything. Okay, the other thing that you should know about me is that I'm a Swiftie and I live in Kansas City. So we kind of own her now, right? So she's a Kansas Citian, I guess you could say. So you're going to see lots of references throughout here for the Chiefs and, Taylor Swift. So want to talk about how I went from patient to provider and how that really changed my trajectory in life. So I think there's two kinds of people in the world. When you have something tragic or unfortunate happen to you, you are either somebody who takes that and lets it empower you and turn it into something good, or you are that person who always asks the why me. And I don't know if you guys can catch that in the first 2 minutes, but I'm not the why me person. So I want to talk about how we built a cardio obstetrics movement from the ground up that's focused in equity, compassion, and science. And so, when you are lecturing, it's kind of fun to learn about who's talking to you. And I feel like giving you a little bit of my history, you'll understand where we're going with this whole lecture. So I am one of 6 kids growing up in a small town in Michigan. And when you're one of 6 kids, you kind of have to grapple for what your role is in the family. And so my sister always told me I was a really ugly baby. So I thought, well, maybe I'll be a dancer. That didn't turn out. And then you can guess by the braces, glasses, and all that things. I was like, well, I'm definitely not, the pretty one in the family. So I have this intense love of animals as well. It's kind of funny. I love animals. I kind of forgot about that until I had my own kid. And then he reminds me every day why I love animals so much because he's also an animal lover. So I thought, well, maybe I'll be a vet. And then I went through high school and ended up playing college softball at the University of Missouri, which is kind of fun that I came full circle and I'm now working there again. And so I thought, well, okay, I'm the athlete in the family. But once you are an athlete and you finish athletics, you have a crisis of identity. And so I wasn't sure then, again, what is my identity? What is my role? And so I ended up going to medical school. My dad is a doctor, which is where I met my husband. We ended up getting married, and funny enough, we both, independent of each other, started out with sports medicine, peds, whatever, and both independently went into obstetrics. So that is a picture of me teaching him how to do a breech extraction. And so then we decided to have a kiddo, and that's where things went really, I don't want to say off the rails, because I believe everything happens for a reason, but really the trajectory of our lives really changed. And as I said to you earlier, you can be one of two people, and I'm going to be that person that lets my passion be my compass and my purpose be my roadmap. And so that's exactly what happened. And so anybody who knows me knows that that does not look like me. So I got pregnant in my second year of fellowship, and I, for a little while there, I was an Ironman athlete, and I thought, well, I'm going to rock this pregnancy stuff. That did not turn out to be the case. And so at 28 weeks, I got sick. At 31 weeks, I ended up delivering our son, Rocco Jr. He's actually Rocco number 5. And he spent 5 weeks in the NICU. And that, I'm sure some of you on this call are, when you are a NICU mom and you are a preeclampsia survivor, your whole life changes, and you really start reevaluating, what does this mean for me, for my family, for my life? And for those of you who are wondering, he's totally fine. That's him and his new puppy. He's 13 years old now. But again, so I delivered at 31 weeks. That is a picture of my delivery team and my husband. Funny enough, you can see him over the over the blue drape there. That is him asking me if they could just tie my tubes right then and there. And I said, can you just let me survive this, please? My liver enzymes, I got admitted 5 times over the course of 7 weeks, 2 before delivery, 1 at delivery, and 2 after. At the time, the diagnostic criteria must involve protein. And so nobody ever really called me a severe preeclamptic. So I never really got MAG at the time until my 4th admission. My liver enzymes were in the 120s. My blood pressures were incredibly high, so high that I ended up with PRES, or a swollen brain, on MRI. And so one thing that you should know is that these types of things that happen to people, again, are life-changing. We know that because of the work we do, but we really need to sit back and think about, how is this going to change this person's life? Because we know that women with severe hypertensive disorders suffer from significant morbidity and mortality. So we know that high blood pressure disorders in pregnancy account for up to 16% of delivery hospitalizations and a significant proportion of maternal deaths. This one really shocks me. Maternal mortality for those people with PRES is 5.3%. I would not get on an airplane if my chance of crashing was 5.3%. So hence, I had 1 child because of that. And again, they account for a significant proportion of deaths. And what I really want to talk about today is not so much hypertensive disorders, but how that realigned my purpose and my goals. Because as I went through the rest of my training and my life, I was diagnosed with, pre-diabetes, and I have an arrhythmia, which I control pretty well with lifestyle modifications, and I'm on a statin, and all of the things that I thought, man, as an elite athlete, this should not have happened to me. And so you start thinking about, why did this happen to me, and how can I prevent cardiovascular disease and adverse outcomes with people with cardiovascular disease, or those who are going to develop them in the future. Also, can I tell you guys how much, I know this is bad, but I love ChatGPT and the images it makes. So I was like, hey, ChatGPT, make a Candyland image of my travel through cardio OB. And this is what we got. Isn't that fun? So after fellowship, so I did my residency in New York, in Brooklyn, which was so fun. I loved that because I got to be, as the Midwest white girl, the minority, which was really cool in caring for people. And it was just such a awe-inspiring experience. And then I went to fellowship at UPMC, and then I graduated, and I ended up moving to Kansas City and started my career at St. Luke's. And so when I started at St. Luke's, I just thought, I'm just going to be a regular old MFM. And I kind of was. However, there was one experience of one patient that, again, these things in your life, look around. There are life-changing moments all the time. And this patient was really life-changing for me. And she had I can't even remember what she had at this moment, but she had some cardiac disorder, who was kind of getting bounced around. Like you guys know, when a cardiologist sees a pregnant person, they're like, eh. And vice versa. If you have an OB/GYN or an MFM who's not versed in cardio obstetrics, they're not going to want to take care of that patient because it scares them. And so this patient got bounced around from her OB's office to her cardiology office to the emergency room. And it just left a really bad taste in her mouth. And she gave us some feedback and said, it was really hard for me to go back and forth, and I never really got any answers. And so we started thinking together as a group, hey, what does this care model look like for the highest risk patients? What can we do better? So this is a kind of, I guess you could call it an ecologic model, although an ecologic model goes up and not all the way around. And so we thought about at the individual level, institutional level, interpersonal level, what can we do better to take care of people with cardiovascular disease that are pregnant? And we definitely identified both at the individual level and interpersonal level that we could have healthcare quality and access to people who know what they're doing improve. And there's got to be better structures of care so that when a cardiac patient hits your unit, you can say, hey, I have somebody perfect for you, and this clinic is going to take care of you, and this is how it's going to flow. And so that's exactly what we did. We said, I identified some stakeholders in cardiology and said, hey, what would you think about maybe joining forces and starting a cardio OB program? We have plenty of these patients. We were at one of the best cardiology departments in the whole country. And, I identified several cardiologists who were very interested. And so we developed a cardio OB program. This is one of our first cardiologists there, Laura Schmidt. And this was one of our cardio OB days. And we got together and made sure that every process involved in taking care of these patients was identified and taken care of. So we had to train the nurses so that they felt comfortable, both the L&D nurses, the ICU nurses, and the cardiology nurses. We had to make sure that both the providers felt good about it. And so what was really interesting was that through this iterative process, we started changing how we delivered care. So when we started this, the cardiologist would come into our unit, the cardiologist would go see the patient, then I would go see the patient, then we talk about it. And I said to them one day, I'm like, isn't this stupid? We're literally in the same spot. Why don't we just go in there together? And so then that led to me, the cardiologist, and our nurse coordinator going in together, putting the orders in right there, giving the patient feedback, answering their questions together. Because invariably, how many times do you see a patient and they're like, God, I have to tell my story again? That eliminated that. It also eliminated multiple visits to the doctor. So there was patient satisfaction there. And it got recognized because what we started to do, and I believe I have some data here for you, is that we started to notice that our care and outcomes improved. And this got recognized by a group of people who work for health affairs and was like, hey, would you mind if we did a piece on your cardio OB program? It seems to be really unique. And so that's what happened. And that's when the ball really started rolling for us. But does it actually make a difference? Like, it sounded cool, right? I will tell you, yes, it does. So what we did, like I told you, is we started looking at our outcomes over the course of 4 years. We started this in 2014. And as you can see, we started with only a total of 31 patients. By the time I left St. Luke's, we had seen over 2,000 patients. Ended up seeing 247. But what you'll notice is as you see patients together, as you get more comfortable, as you're learning from each other, as you're doing this kind of PSQI, where you are looking at problem solving them, implementing new structures of care, that things actually improve. And you can see that as that happened, we got more comfortable delivering these people later. Our vaginal delivery rates went up. Our utilization of the ICU went down, and with the gestational age, our birth rates went up, and our average hospital stay went down. So we really did improve care and outcomes for these patients. So through that, we thought, well, hey, we've landed on something that's really cool. Maybe there's nothing I hate more than remaking the wheel, by the way. I was just on a call today with another University of Missouri, Kansas City group, and we were talking about how we should just join forces to train the fellows. Anyway, that being said, we thought, well, if we're doing this, and clearly we're doing it well because the numbers show that we are, why don't we put this out there for everybody to try? And so we wrote this paper on how to develop a center of excellence. And, again, process flow wise, you have to think about the vision. What are you trying to accomplish? What does this look like in your design and development? Because I know there's cardio OB programs all over the country that do it differently. And that's actually what we'll talk about with Hope. Who has to be involved? Well, clearly it can't just be the doctors and the nurses. You've got to get buy-in from your administrators. You got to advertise so that people know you're out there. You got to educate like we talked about. And then billing and reimbursement are a big deal. And then how do you implement that? And so when we did this, in our minds, we thought we have to keep the patient at the center of everything because that's really why we're doing it. And when you do that, you have to think of all the pillars that hold up that patient. And that's what you see here. What I love about this image is that there is a care continuum of not just the pregnancy, but prior to pregnancy and postpartum, which is actually really important. So we think it's cool. Our providers think it's cool, but do the patients like it? So we asked the question. We put it out to our cardio OB patients and we said, did you think that your quality of care that you received was good? Did you like seeing the cardiologist and the obstetrician at the same time? Did you think communication was better? And did you think communication between inpatient and outpatient were really good? What I thought was really cool is the highest score here on a Likert scale was that they loved seeing people together. And so then we asked, prior to coming to this cardio OB program, did you have an appointment with cardiology? Did you have an appointment with OB? Were you intimidated by multiple providers? I love this question. Only 17% said yes. So really, it's nice for the patients from a communication standpoint because then they don't have to tell two people the same story at different times. Did you, again, perceive that communication was improved? So on and so forth. And then one of the things that really came out of this that we thought, well, we could do a whole lot better job of this was, we think our counseling is great, but we could improve upon our counseling for safe contraception. So overall, we thought, oh, this is working. People like it. We have better outcomes, but it really has to do with the team, right? So I love this, that the teamwork, the dream does not work without the team. And so we obviously were onto something. And when you don't practice in a silo, things turn out a lot better. And so going back to our Candyland, I worked at St. Luke's for a very long time, and the work that we did got our department recognized by our maternal mortality board. And so I ended up working for the maternal mortality board for 9 years. That was one of the great honors of my life. I was there on the ground floor when we were like a nothing, we didn't have statutes around our protection of adjudicating these deaths. And now we are one of the best payment boards in the country. I realized, like Seinfeld, you got to get out before you get put out to pasture. And so I also recognize that you have to make room and space for different voices. And so I stepped down last year and had an ICU cardiology woman who is Indian take my spot. And I think she's doing a fantastic job. And so what I started to recognize, though, when I did that work is that, man, there's a lot of cardiology deaths in not only our state, but in our region. So Dr. Graves and I work on the ACOG Maternal Mortality Board together. And what you see here with all the stars are the states that are in our district. And what you can see is we are the deepest purple states on the map, which means we have the highest maternal mortality rates and the highest rates of cardiovascular related maternal death. So you have to think about, in this region, not only is overall mortality rate important, morbidity is significantly important, but we have significant disparities in our maternal mortality rates by race. One of the reasons I thought it was really important for Dr. Trivedi to be on that maternal mortality board is because I'm not a minority, considered a minority woman. And who needs another white woman, pardon my French, telling people what to do when the problem is affecting Black, Brown, and Indigenous women. And so I think that's something we all need to think about. Do I want to be involved? Yeah, of course I do. But is it the right thing to do? And so I think we need to elevate those voices who are getting impacted by this the most. And so we recognize that cardiovascular related deaths are rising across the country. And you can see here the rates of CVD in pregnancy exactly parallel the rise in maternal mortality rates due to cardiovascular disease. And so I just want to share with you a little bit of our Missouri data. You can see, I'm sure it's very similar to Tennessee, that cardiovascular related deaths are a leading cause in a aggregate years, 5-year grouping. And most importantly, I think, is that these deaths are occurring in the postpartum timeframe. And so one of the things that Dr. Graves and I worked on together as part of ACOG is asking these other services, because what happens when we care for these patients, we're really good at caring for them while they're pregnant. As you can see, not a whole lot of deaths occur due to cardiovascular disease in pregnancy. Because what happens is they get lost to care in the postpartum timeframe. The physiologic changes of pregnancy unmask unseen cardiovascular disease. And when they're not seen and they have increased risk, they're showing up at the urgent cares, the ERs, they're having multiple touch points on people who don't really care for these people, and again, who are scared of them, and then they're getting sent home, and then they end up on our maternal mortality list. And that, one of the things that we do in Missouri is that we, not only do we adjudicate these deaths, but we also have an opportunity to say, was it preventable? The answer is yes, up to 80% are preventable. And cardiovascular related deaths are one of the highest preventable deaths. But also, what I think on the left side, which I think is really important, is that we also think about contributing factors. So there's 5 domains when you talk about preventability. Where was an opportunity for prevention? The patient family, which is always challenging because you don't want to blame patients, but there are things like health literacy or didn't understand when she was supposed to show up or blah, blah, those kinds of things. Provider, facility, community, and system. And so invariably, when we look at this, let me go back one slide. You'll notice that provider, whenever I present this, people they're really upset about it because, again, we're not blaming, we're just saying, hey, there's an opportunity to do better on our end. And always within that domain, knowledge and assessment are always a problem. So what can we do to bridge the gap for maternal mortality? We have to work with our PQCs, right? So, oh, here I go again. Okay, we stopped at the PQC. That's where we're supposed to stop. Okay. So one of the, in Missouri, and I would invite everybody to join our webinar. Connie, I think it's like next week, right? It's the 29th at 5 p.m. where we're actually going to be talking about this. How does the Maternal Mortality Board interdigitate with your PQC? Because the Maternal Mortality Board is the recommendation arm, and the PQC is really the intervention arm. And so we said, okay, let's try this on for size. Let's give a recommendation and see how it goes. So we started with the low-hanging fruit. We went with pregnancy-associated death first, and we noticed that there was quite a few women in the state of Missouri who were not wearing their seatbelts. And so we said, okay, let's do this PSA. What you see there is the PSA that was put out. And let's come back in 6 months and see how it went. What we realized, though, is that when they came back to us, we're like, I've never seen this poster. So if I haven't seen it, who else has not seen it? And so I think it's really important. And one of the things we did really well in the early days of our PQC and PAMR is we asked the question, and we listened. And so we asked, have you ever seen this before? If so, where? And it turned out we were not delivering healthcare and information where the patient needed it, from who, and how. And so what we did is in the state of Missouri, we said, well, if this is happening, let's do it on a bigger scale. Do people even know that maternal mortality is a problem? Let's ask the general public age 18 to 70 years old, because some people get their healthcare information from their grandmas. Do you know this is a problem? So are you aware that deaths are a problem in your state? pregnancy-related deaths? Do you think that they're high? Do you know somebody who has died? I just want you to pay attention to this, you guys. So we polled 1,700 people. We used a company that was able to hit every single county, every single demographic. We got quite a few natives, actually. Every single age group, so that we could have a really good sampling of what people knew. 14% of people polled knew somebody who died in pregnancy. But they're not dumb. Look, they know that pregnancy-related deaths are high. And so we asked, who do you think is most effective? They were pretty good about this. Look, Native Americans, Pacific Islanders, Blacks. You have to put it at the 5th grade level. So poor, those without insurance. So they were pretty smart. They knew. What time do you believe is the highest? This was so important for us. Check this out. So I showed you that maternal mortality is highest in the postpartum period. Nobody realized that postpartum was supposed to be watched. So that was an eye-opener for us. I think I'm going to sneeze. Maybe. So then we asked, what health problems do you think can happen as a result? Again, they were pretty good. But when we asked the questions, what 2 conditions do you think are most commonly connected to a pregnancy-related death? 3% identified cardiovascular disease. So we need to educate people in the postpartum time frame, and we need to tell them that it's cardiovascular disease. And so that's what we did. So what I want to show you here is that our pregnancy mortality review board, that these things happen all over the state. So these are our birthing centers, right? So we have level of birthing centers all over the state, but we only have 5 level 4s. We have 2 in the center, 2 down here, and we have 1 in the center, 2 down here, and 2 in St. Louis. So not very many opportunities to get these people to higher levels of care. And so we asked by region, because look, if you look at deaths, there's the deaths here. Lots of them are happening in St. Louis, but they're also happening in rural. So we wanted to know, do you guys know that your area is significantly impacted? And so we broke it up into quadrants to understand, because this, I will tell you, is incredibly homogenous. There are barely any hospitals down here. It is predominantly white. And we wanted to understand, does that, like having a very different demographic, change the answers throughout, or St. Louis or Kansas City? And so when you broke it down by age, race, and region, broken down by different age groups, what you find is that the younger population tends to know that maternal deaths are a problem, that they know that they're high, and they knew somebody, not the older. So if your patients are getting their information from their mothers or their grandmothers, that's an opportunity for intervention. We know that races that are significantly impacted, like Black, American, Indian, and Pacific Islanders, tend to know somebody that died over their white counterparts. And do you think that deaths are high? Those rural regions did not answer yes, even though it was impacting them. So again, we asked the question, well, were you scared of dying? And the younger population was more likely to say somewhat, very, or extremely. Again, those who are significantly impacted tend to answer yes more. And again, we did not identify in the general population that, the time period for death was highest in the postpartum time frame. Now, this is super interesting. Okay, so the general population, we can focus on delivering information about cardiovascular disease in the postpartum time frame. What about providers? Again, remember, providers, knowledge and assessment were the biggest problems. So what we did at ACOG District 7 is that we pulled an 8-state. We did the same thing again. We pulled the 8 states and said to the providers that are seeing them in the postpartum time frame, family medicine, emergency medicine, cardiology, hey, do you know this is a problem? Are you screening for this? What I think is most impactful is this one right here, and I thought I highlighted it, but can you identify cardiovascular disease as the #1 cause of death? Less than 5% of people, which I think is crazy. So it's not only the patients, it's the providers. We've got to get to both of these groups and let them know this is a problem. So that's where I landed with my project. So what I've struggled with in this adventure of cardio OB is that when we counsel patients and we talk about, well, here's your risk, this is what you're at risk for, this is how we should care for you, we're extrapolating data from, again, a very homogenous group of people in Canada who are not nearly as obese, who have better access to care, universal health care, who don't lose their postpartum funding for postpartum care, and who generally are a very different population than us. And so when you think about that, you really can't extrapolate data from Canada to an American diverse population. There's another scoring system called ROPAC. And again, I should say, these are to score people who have known cardiovascular disease to look at what their risk is for an adverse outcome. And when I say adverse outcome, the CARPREG only really looked at cardiac outcomes. They didn't look at whether you have a rate of preeclampsia, what's your baby's risk of going to the NICU. And ROPAC only included 96 people from the United States. So again, not generalizable. So we decided to do something about this. Also, do you guys get the reference, Ozark? It's funny, right? So this all started with an idea. So now you understand how I landed here. Through my course, I have noticed problems in the system, problems with delivery of care, and we have to fix them. And so we started with just the call to action paper. This was in 2018, and we said, hey, we need to fix this, you guys. And it really garnered a ton of attention. And so that same year, we went to the Cardiac Problems in Pregnancy Conference, which was in Bologna, Italy, which was fantastic. And we went there with one goal in mind. And we said, we are going to find people who are just as passionate as we are, and we are going to build this thing. And so we said, we need our own risk stratification model. We need to follow women so that we can build these things. And we need to find out what are the best structures of care delivery, because the way we deliver care matters. So what are those and how can we improve upon them? So in 2018, we launched the HOPE study, and we're met with incredible enthusiasm. And through that, we were able to get philanthropic support for the pilot, because you can't do anything without pilot testing it first. And so we said, okay, let's trial this between 2 centers. And so we were very fortunate to receive multiple sources of funding to put on the pilot between St. Luke's Hospital and Mass General. And so what was this? This was the first US multidisciplinary-based study that prospectively evaluates outcomes of birthing people with known cardiovascular disease through 1 year postpartum. And that is so important because people are dying in the postpartum timeframe. We can't just forget about them and take care of them in pregnancy. We've got to follow them up. And so our pilot study was 75 people. Not only were we looking at clinical outcomes, because anybody can look at clinical outcomes. As someone who's sitting in front of you who suffered an adverse event, I can tell you that your quality of life matters. And it matters to how you care for that baby, and it matters how you interact with your family, and it matters for everything you do. And so how come we are not asking people, does having cardiovascular disease and what happened to you impact your quality of life? Also, is the way that you're treated within this country as a Black or brown woman or an Indigenous woman impact your outcome? And how is it that we're delivering care that actually improves how you do? So we are identifying characteristics associated with maternal morbidity and mortality with a focus on racial disparities and inequities. And so we are not only looking at quality of life, experiences of discrimination, experiences at birth, we are also trying to figure out what is it about patients that puts them at increased risk, not only for cardiac outcomes, but for adverse pregnancy outcomes and neonatal adverse clinical events. So what you see here are the 3 composite outcomes of things that we are evaluating in the study. And so in the pilot study, we included people older than 18. We really wanted to do the younger population, but every state has a different definition of an emancipated minor, and so that kind of got challenging. You know, as much as we wanted to include all languages, that is expensive. So we chose English and Spanish. The patient had to be pregnant but not delivered yet and not discharged from the hospital and have some kind of underlying cardiovascular disease. Obviously, we could not enroll prisoners, people who weren't able to consent for themselves and had no means of contact because we were following up for an entire year. And so what you can see here are the domains of which patients must have certain type of cardiovascular disease. So I want to present to you some of our preliminary data, which is not published yet. But I want to show you just how different we are from Canada. So let me just give you a quick rundown. In Canada, I think their rates of hypertensive disorders were 5% in their cardiovascular population. So we looked at our 75 patients with an average age of 30 years old. We had a decent mix of white, Black, Asian, and I hate othering people, but we, you know, that's the only thing we could do with one person. You know, various types of insurances. I hate married too, because that's not a proxy anymore. So kind of think we should get rid of it. Various levels of different education, known cardiac condition, whether they had a prior intervention like a CABG or a heart transplant or anything else. If they had underlying comorbidities at the time, and that's really important, right? Because if you have an underlying comorbidity, you're at significantly increased risk for adverse outcomes. And so we had to adjust for that. And you can see here that our cohort really didn't have a whole lot of comorbidities, the different types of cardiac disease, and then obviously the neonatal outcomes. And so what I want to share with you here is that these patients overall had at least one visit in the first trimester. So they had good care. The majority of people underwent an induction of labor. A small percentage had an operative delivery, and this is better than any C-section rate I think I've ever seen in the country. So this was the planned method of delivery. We still hit it pretty much on par when it came to what we planned. This is what I really want to share with you, is when you look at the pilot data, almost 50% of patients with known cardiovascular disease will have an adverse pregnancy outcome. Diabetes, polyhydramnios, oligohydramnios, hemorrhage, I'm going to show it to you, hypertensive disorders. I mean, think about that, you guys. Who is missing from the United States Preventative Task Force guidelines on who needs aspirin? These people. There was a 17% incidence of having an adverse maternal cardiac event, and 30% of these patients had their baby have a neonatal adverse clinical event. So when you break down the APOs, a significant number of patients had hypertensive disorders of pregnancy. I also want to point out 8% of these patients hemorrhaged. So we really need to be paying a lot of attention to this cohort of very high-risk women. And so the pilot was a huge success. This is the pilot data. We went on to get funded by the National Institutes of Health, so the NHLBI, so the Heart, Lung, and Blood Division, to do this nationwide. And so Dr. Graves is one of our sites, and she's been doing a fantastic job. But these are all the people who are involved in this. So our goal is to enroll 1,000 women over the course of a year and follow them to look at their outcomes so we can have a population-specific risk guidance so that when we're counseling our patients, we have pretty good numbers for them. And what I think is really cool about the HOPE project is that we were incredibly intentional when we recruited the HOPE states, which I'll overline in a second. We were intentional about making sure that those states that had the highest maternal mortality were included in the HOPE registry. And so I wanted to leave 15 minutes or so for questions. But, you know, as we think about our own careers, what's important to us, and how we're caring for people, I think that, you know, we know that the data says that women are dying from cardiovascular disease. We've seen the disparities. Now I think we need to let hope come into every woman's lives so that we can change this trajectory. When you think about structures of care, and that is the other thing we're evaluating in this study, is the ultimate goal is not only to build a registry that can develop risk models for these patients, but we want to understand from each one of these cardiovascular sites, these cardio OB sites who are implementing different structures of care. Some of them have a multidisciplinary team. Some of them have a coordinator. Some of them see the patients together. We want to understand what are the essential and critical components of care that every cardio OB program should have so that their outcomes can improve. We want to empower providers. Don't be scared of the pregnant patient, right? We don't want cardiologists and family medicine and ER docs to be scared of these people because they are the ones who need help the most. And we want to keep the patient at the center of all of this, which is why that image I showed you had the patient at the top with all of the pillars at the bottom. And we want to spread hope because this is a movement more than it is research. We're really giving people the gift of life. And in those patients that can avoid a NICU stay, can avoid an adverse outcome, it means the world to them. And so these are all of our hope sites. You can recognize some of the people in here. And we just want to thank them because without them really pushing to identify these patients, enroll them in this project, this would not be possible. And what I want to end with, because I think we all have people in our lives who are seeking fame and fortune. I think that, I didn't ever intend to be here. And that was never supposed to happen this way to me, right? Like I told you, I was supposed to rock this pregnancy thing. But I think everything happens for a reason. But I think that great leaders don't set out to be leaders. They set out to make a difference. And I'm imploring you to make a difference because it's never about the role. It's always about the goal. And the goal is to never let anybody suffer like that again. The other thing I want to say is that I would not be here without my mentor. And he's a cardiologist. And we look like we're jumping really high there. It's like it's a trick of the eye, you guys. We barely jumped off the ground. But I wouldn't be here without him. And he believes in the cause and he believes in me and my ability and what happened to me. And I think that if you find that mentor, you cling to them like a booger. You don't let those people go because they will help you achieve your goals. And with that, we have 15 minutes of time left, and I'll take